All right, thank you to our speakers. Now the panel is open. Uh, it's time for the questions and answer session. Please make your questions as brief as you can.
Good evening. Oh, yeah, I just met Mr. Biggs, and I told him I'll be here till he speaks, so he's kept me here till the end. Just a brief comment. I've learned a lot of things today. I'm an associate professor of medicine at Howard University. I've been practicing medicine this year, makes it 40 years. I'm glad I'm about to retire because I don't understand what's going on. Who is a spiritual herbalist? I came from Nigeria 40 years ago, and I know there are herbal things you use. Are they scientifically proven to work? So what is a spiritual herbalist? And for you, what is the best way to find a mental health provider without being identified? Like if I wanted to see you without being open, I mean, how do you get, because that's part of the problem. People don't want to be identified as mental to see a mental person. So that's the question. What's a spiritual herbalist? And can I be your partner?
Of course you can. Okay. So for spiritual herbalism, the reason why I went
I
this
think the
route.
microphone is not wrong.
Oh, it is on. Okay. So the best way I could think about describing spiritual herbalism is looking at our indigenous and African practices.
Yes.
And recognizing that, and I love that you showed the picture earlier of the Haitian woman who was using the herbs. It's recognizing that every plant that we have access to has a story. It has a wisdom for us. And it has been used in such a way throughout generations. I very well could have went just the straight clinical herbalist route, which would have been much more palatable for people. But it was very important for me as someone of West Indian descent, I'm of Jamaican descent, to learn the practices of my people that has got us to this point. So I apprenticed with a very well-known herbalist right here in Brooklyn, Empress Karen Rose, who was able to teach me not only the clinical aspects of the herbs, but also how it was used to support the spiritual needs of the people that we were working with. Because sometimes it's not just working with high blood pressure or working with, digestive issues, but it's also how do we support someone who's going through grief? How do we support someone who's going through sexual trauma, who is learning how to get back into their body? And that's where the spiritual piece comes in. So in short, it's really just using the practices and knowledge and the wisdom that we already had within our cultures that, sometimes we haven't touched into it and it is at risk of being lost.
Yeah, and thank you for staying. I appreciate that. I told you that I think it would be available online, and you insisted, so I appreciate you staying. But I also, I think that how we can sort of find a provider without talking about it loudly, one of the silver linings that came out of COVID-19 was telehealth. So you can literally be in the comfort of your home now, and no one know that you're talking to any sort of provider. And so I think that that's one of the ways in which I think South Carolinians, in particular in my context, have really sort of made mental health a priority now because they're not showing up in buildings that are not nondescript or to the local mental health center where they know that their family members might be working and have access to their medical records. So now with the push of telehealth and telepsychiatry, there are patients that are coming from all over the rural South that are talking to me via their cell phones. And I think that's one of the ways in which we're lowering the barriers and increasing health outcomes for individuals with psychiatric services.
Dr. Smith, you want to add to that question?
Certainly. I think that a moment for optimism. We've seen, for example, with the Francophone African group and people being referred to our program at Bellevue and all the stigma and everything that we've been talking about. And when we first began, most of the referrals were clinical referrals, coming in from other health professionals, legal professionals, et cetera. But over time, that has really shifted. And what I'm finding now is a grand majority of people who are being referred for our services within a big, centralized hospital are from within the community. And people now that we have this track record, I get stories every week. People like, I saw someone on the subway who just seemed so despondent, where they were crying, my sister, what's going on, and talking about these things and sending them. It really normalized. And to not put things in a thing like, oh, you're sick and you need help. Again, we're not dealing with sick people, we're dealing with a sick situation. It's not abnormal people, it's abnormal circumstances. And I really feel that little by little, it's moving us in this direction. And it's one thing, to have a group that's been running for 18 months. That's quite a that's quite an accomplishment in this environment, in this setting. But to have one that is now pushing into 29 years, that talks to the strength and the buy-in of the people who are engaged in the group. It's not my expertise as a group facilitator. It's because it is now theirs. And I do believe that hopefully that is a model that can be shared elsewhere.
Okay, we have another question. Please go ahead, be brief.
Yeah, yes, of course. Hi, thanks again to all three panelists for very interesting and entertaining presentations. Dr. Briggs, I do share your sentiment that mental health should play a much more pivotal role in conferences like this. Two questions. One for Dr. Briggs. We are in the digital age, and I am not a conspirational theorist, but I do believe that we are in an age whereby there seems to be what I call a capitalist type of social engineering, where people's minds are being manipulated and changed. I've been an educator for 20 years. I now teach online, and I could tell you that there are serious mental health issues. So I wanted to know from the psychiatrist or psychiatric profession, what sort of adaptations are being used or developed or even contemplated to try to address some of this cognitive and mental kind of decay that seems to be going on. And for Dr. Smith, I mean, this might be a bit controversial, and I looked at the theme of your presentation. I come from a very small island nation, and we are very warm-loving people. However, we are faced with a migration crisis. And this is from a larger nation right next door to us, Venezuela. And what happened is that whilst we want to have a very humane, empathetic immigration or asylum policy, it's impractical with the kind of capacity constraints that goes with a small island. So in terms of your experience, what do you suggest that we do to craft a humane type policy that can meet and deal with some of these traumatic issues? Because most of the people are economic migrants and not necessarily asylum seekers. And I want to make that clear. An economic migrant is not an asylum seeker. Yeah? So I hope my points were clear and you understand what I'm asking.
I think you were very clear. So thank you for that. Yeah, I think that technology and the advancement of technology is not something new. It is not our age problem. Ever since the advent of any sort of technology, individuals have had to make adaptations to that technology. In the age of misinformation is my concern. In an age where there are alternative facts or people are making up facts as they go is the issue. And so the thing that I'm really sort of encouraging my patients to do from a psychological perspective is to turn off social media, to turn off the news, and be a consumption of community and personal interaction versus going to the internet for your socialization. And until we get back to living room conversations and connections, there was a recent study that said isolation is as worse as smoking 15 cigarettes. Did you hear what I said? I said isolation and being alone is like smoking cigarettes now. And so we spend so much of our time consuming information from the internet and social media that we're actually doing ourselves a huge disservice in terms of our health and our health outcomes. So technology is not the issue. AI integration is something that I think that all of us can agree in this room as healthcare professionals that it has actually helped us to do our jobs more effectively and more efficiently. So it's not the technology or the mind manipulation. I think it is the overconsumption of social media, and we don't have an appetite of socializing in person-to-person situations now. And I think that that's the thing that we need to concern ourselves with.
And then the second question, I believe, is Dr. Smith about the
Yes.
how can we create these what he described as practical solutions.
Yeah, I got it. I got it. And I think that one of the challenges that we face, but also one of the blessings, is that as service providers, as people who are engaged in the healing process, that is the crux of what we bring forth. Now, of course, this is partially determined by social determinants of health, and it has great impact on those determinants of health for the larger community. But I think that sometimes, and I draw a parallel to our engagement in the asylum process, I always tell my clinicians, our trainees, that we are not there to convince the asylum officer, the immigration judge, one way or the other, but we are there to shed light where there may have been shadow, to provide nuance where there might have been a lack of clarity before, so that those adjudicators and decision makers can make a more informed and just decision. And I sort of take that in terms of policy as well. That in terms of what is going on with your nation and the influx of people, what is the humanitarian need, what is going on, what is the pain of particular people who are coming, but then if there's so many people, what is the impact on society? These are things that you and others in the service providing field can shed light, can provide data, not just the quantitative data, but the qualitative, spiritual. Here's what's going on so that your adjudicators and decision makers can make a more informed and just decision. So I don't mean to pass the buck on that, oh, we shouldn't be the ones telling them what to do, but it's not effective when we do that. We become more advocates than experts. And I think we need to lean into our expertise so that not only are we listened to in this particular discussion we're having, but downstream, we will continue to be listened to and continue to have impact so we can build this frame.
Okay. All right. You have a question? Be brief.
Okay. Is the mic on?
This will be our last question.
Hello. Okay, sure. My name is Stephanie. I'm a board certified family nurse practitioner with specializing in maternal child health, and I also do a lot of alternative energy work. And I just have a question for you guys. I wrote it down here. Can spiritual practices be protective factors in communities facing mental health disparities, or are they sometimes dismissed as delusional or unscientific by providers? I asked that specifically because in doing womb work and Reiki, I'm a Reiki master as well, healing work, I hear so many different stories, and I feel that there are a lot of clients who are afraid of the stigma of maybe having spiritual gifts or things that can't be proven by evidence. And I was just wondering if you guys have any insight or any experiences, anything that can relate to the question in regards to that particular area of the disparity.
Absolutely. I think you hit the nail on the head by recognizing, bringing up that when people have certain gifts, that they're oftentimes dismissed very often. And I've seen that even with people who are looking for me as far as like providing care, that's one of the first questions that they ask me, like, how do I deal with people who come from other spiritual practices or from other cultural practices? And one thing for me in understanding that is that I invite all of that into the room with me. And it kind of goes back to accepting their word for what it is. And again, not trying to pathologize what they're saying. So if I have someone who does come to me with some kind of like clairvoyance or anything else like that, it's accepting like that is your spiritual gift. How do you get to work with that? How has that helped you in your healing? And not just dismissing it as schizophrenia or anything else like that, because that is, again, how the re-traumatization happens. Because a lot of those diagnoses that we have to use within the DSM is because all of these other gifts that we have been dismissed. So for me personally and other practitioners who I work alongside, we accept that into the room because we know where it's coming from. We know how it has been used within our cultures and in our communities, and it is a powerful tool for them.
And I'll just say briefly that religion in the South is a protective factor for sure. But I think one of the things that I talked about briefly in my talk was religious ridicule, and it is not just enough to pray it away. I think a lot of people think that they can rely on their religion to pray things away. that are not necessarily demonic or spiritual in nature when it comes to mental illness. And this is, and I don't think, in my humble estimation, that is true in any other part of medicine except for mental health. You don't tell people to pray away hypertension. Some faith traditions do, but not largely. Or you don't tell people to pray away diabetes. But when it comes to mental health, and we have a poverty of knowledge in this area, and the low-hanging fruit is to assign it to spirituality when there may not be any. So I think on the one hand, it's a two-edged sword. It's the spirituality can be protective in times of trauma and, in times of wanting to be comforted, but then also I think the misuse and abuse of that can look a lot more damaging to a lot of people. And that's why I think folks don't come to me sooner than they should, because they've prayed, they've gotten the oil, they've gotten in lines, they've given their money toward these things, and they haven't gotten the outcome. And it really is deflating for their faith, because then they say, we're not faithful enough, or God didn't hear our prayers, and therefore this must be some sort of punishment. And so I love spirituality, and I think it's really useful, but I think just like anything else, it needs to be governed in a way that looks like science and spirituality working in tandem with each other.
And that's that middle ground piece,
Okay.
right?
Yeah.
Oh, sorry. Looking at this spiritual bypassing versus like the complete ignoring of everything else, right? Because even with everything that I mentioned before, if someone needs the medication, take the medication, and we could still use everything else to support the full person. There has to be that balance in middle ground for sure.
I really applaud those responses, and I feel that there have definitely been times people I've worked with who have leaned more into their faith as a very constructive and supportive factor. There have been others who have had crises in faith due to the trauma that they have been through, and why has my God abandoned me, or such other sort of questions. And with, for example, the Francophone group, where we have Muslims and Christians and Hebrew Israelites, people who follow what might be considered more traditional sort of faiths from their particular homelands, that oftentimes the sort of edicts of a particular faith are pushed aside, and they focus much more on the spirituality. And I feel almost like they do this work in themselves, like, what is a sort of divine commonality that is here, and have worked really wonderfully there. And it feeds into that sort of community support. And what, Ms. Miller said, many people, it's not even practices of their faith, but perhaps it's communication with the ancestors, cherished loved ones, in the dream state, and what they hear in the dreams. And am I crazy to think this, but when someone worked with a woman from Sierra Leone who had seen her family murdered in front of her and was, sort of chronically, passively suicidal here, what have you, and having dreams where her mother, dressed in white, would be next to her in the bed to reach out and calm her and say, we're okay. We need you to be okay. You have work to do and all this. Would I ever look at that and say, oh, that's a psychotic process and this and that we need to? Not at all. This was an adaptive, constructive, spiritual, holistic thing coming from her. And I felt like I was privileged that she would share that with me, and to be able to support her to move forward and see her progress. Yes, there can be pitfalls, there are challenges, but this is not something we should shy away from. This is a discussion we should be engaging in with our clients, again, from a very humble perspective.
Okay. This concludes the 8th Annual World Health Conference, co-sponsored by Health First. Thank you very much. Medinover, thank you very much, and Harvard University. And the College of Medicine at SUNY Downstate. So I now turn the conference over to Dr. Paul for closing remarks. So thank you, panelists.
Well, I'm not going to keep you guys any longer. Thank you for giving up your day to be with us today. I'd like to thank our partners, SUNY Downstate, Health First, Howard University, especially the moderators, Dr. Salifu, Dr. Pinkett. Usually now I wear my other hat as beggar-in-chief for Medinova. We have a QR code. If you have an opportunity to take a picture, no amount is too small for us because whatever you give adds to what we have. So I thank you once again for coming today. One last thing, I don't know if Elizabeth is here, Angela. I'd like to introduce you to the backbone of this conference. We're missing Raymond, but Elizabeth, can you stand, please? Angela? Without them, this wouldn't happen. Okay, I thank you, and also the partners from Downstate this year, Dr. Straker, Edlin, all of them. I think. Oh. So, get home safe, drive carefully, and thank you, and we'll be here again next year.